by the speakers and also distributed through our networks. Please also remember to mute your microphone and turn off your video to allow for a smoother workshop. If you have questions or comments, please use the chat function. We will be taking it throughout the presentations, and we will introduce them during the Q&A sessions that will be hosted by my co-host Petronille and myself. So we have a very interesting agenda. If we can go to the slide of the agenda, please. We will introduce briefly. We will introduce briefly both unCoVer and PHIRI projects, and then afterwards, experts from different backgrounds will be presenting key topics where communicating science to the general public is essential, but not often an easy task. We will discuss topics such as vaccine safety and efficacy in the role of emerging variants that will be introduced by the first speaker, Gunhild Nyborg at the Oslo University Hospital. We will also discuss and get to know better the opportunities and challenges for big data against COVID-19 by Alejandro Rodríguez from the Department of Computer Languages and Systems and Software Engineering at the Technical University of Madrid. We'll have a short Q&A session where we will tackle your questions in the chat. And then we will move to the do's and don'ts when communicating science information to the public by Hernâni OIiveira from the University of Porto, the head of communications. And finally, we will get into an interactive session on infodemic management by Elena Musi Elinor Carmi from the Liverpool University and the University of Dundee, where participants will be introduced to the FakeNews Immunity chatbot, a tool that aims to increase resistance to misinformation in our societies and teaching us how to spot misleading information. During this session, towards the end, participants will be divided into breakout rooms so that we can interact a little bit more directly with the tool. Next, please. So my name is José Peñalvo, and today I'm speaking on behalf of the unCoVer network, which is a functional network of partners capable of harvesting and using real-world data derived from the response and provision of care to COVID-19 patients by health systems across Europe and internationally. unCoVer was conceived last November, tapping in the unfortunately massive number of COVID patients admitted to hospitals across Europe. These patient encounters, next please, these patients' encounters with the health systems in Europe have left behind a vast amount of data, often called real-world data, that can be used to complement findings from other more traditional interventional trials. Next, please. unCoVer was funded in November last year with 29 partners across 18 different countries in Europe and elsewhere. And our objectives, next please, relate all to finding synergies and complementarity across partners in terms of data expertise, clinical and epidemiological expertise. And we aim to find a structured way to answer efficiently COVID-19 related questions using harmonized data, and to provide rapid evidence-based findings to help easing the current pandemic. Next, please. We are structured in 6 different work packages, from data identification, mapping out the ethics and the data protection from each data set, a work package on data harmonization, and a subsequent work package for data analysis and the development of a toolbox. A work package 5 on dissemination, where today's workshop is framed, and that is led by our colleague David Pereira from the University of Porto, that I am thanking for the organization of this workshop, along with Gloria Asensio, Gloria Soriano, I'm sorry, our project manager. And next, please. You can find all information about unCoVer in our social media platforms, where you can also find the institutions and the individuals that are working hard in this unique effort. And I give now the word to my colleague Petronille from Science Center.
Thank you so much. So good afternoon, everyone. We're very happy to have you here indeed to talk again about this very important topic, which is communication in health, and especially in the area of COVID-19, as José very nicely explained. It has been a real challenge for many of us being exposed to this. So we're very happy to have this joint workshop together with unCoVer to talk about this specific topic. And why do we want to bring up this specific topic? Well, you're not alone, and there's, I mean, many people are experiencing this overflow of information that is being spread across Europe with regards to COVID-19. And this has also rightfully been pointed out by the Director General of the WHO, saying we're not just fighting an epidemic, but we're also fighting an infodemic, so an overflow of information, both right and wrong, that spreads across countries in a similar way as an epidemic. So just a few words about FakeNews. What is FakeNews? Well, we are a research infrastructure, and what we try to do is we try to facilitate and support data-driven population health research across Europe, but we also work on exchange of best practices and to support decision-making. So we have 41 partners in 30 countries around Europe. And what we focus on is both the indirect but also the direct effects of COVID-19, but we mostly focus on this wider impact of COVID-19 on population health. And how we do that is we have some use cases that are testing a federated approach to doing data analysis, real-time data analysis on dedicated topics. We are also looking at methodologies that countries are developing to look at the impact, the wider impact of COVID-19. We have a health information portal, which I'll touch upon in just a second. We also operate with a rapid exchange forum, which I will talk more about. And we work on foresight, modeling, and scenario building, which I just want to mention as some of our activities today. So I will just focus on two of our main activities, which are specifically relevant for infodemic management and for information that is spreading across countries. So we have set up a portal which is accessible at www.healthinformationportal.eu. And on this portal, you can find information on national databases that are available in countries, that are routinely collected in countries. You can find information on different projects that are operating in health information across Europe. And you can find different data providers. And that's quite helpful because if you want to know what kind of data sources are available in countries that are reliable, you can go through this website and find a lot of information about it. Next, another interesting activity of us regarding information management and infodemic management is a rapid exchange forum. So what we've been doing is every 2 weeks, we've been meeting together with public health institutes across Europe to discuss specific research and policy questions that have been raised in countries. And so this can be exchanging of best practices, but also guidelines, standards, reports, and initiatives. And these have been proven to be quite helpful for countries in order to discuss dedicated sets of information. And just to give a few examples, what kind of topics are being discussed, well, we've been talking about recovery certificates, about nudging techniques, about mental health, about variants of concern, testing school children, long COVID, and many more. And I am actually hoping that you can see my correct screen. I hope so. Let me just double check. Or Jose, can you confirm that you can see my full screen and not my annotated version of my screen?
It is your full screen.
Okay, so perfect. All right, and just to add on that, we've also been discussing, so if you have any relevant policy or research questions with regard to COVID-19.
Petronille, we see currently your thank you screen.
So it...
The last slide.
Okay. That's really strange. I don't see a thank you screen. But okay, I will just stick to this, and then I will go to my last slide anyways in a second. So just to say, if you have any questions with regards to health information, our infodemic management, if you have any questions regarding COVID-19 and policy actions or research questions, don't hesitate to reach out to coordination@cienzano.be, or just reach out to us through our webpage. And that will be it for me today, and I'll be happy to give the floor back to José. Thank you so much.
Well, thanks, Petronille. So let's just go to our first lecturer, as I mentioned before, Gunhild Nyborg. If you can please start sharing your screen. Thank you so much for being with us today.
And I will share my screen. Okay.
Yeah, perfect.
Okay, can you see my screen in there?
Yeah.
Presentation?
Yes.
Good. Yes, thank you, first of all, for inviting me. My name is Gunhild Nyborg. I'm an MD with a clinical background as a GP and in geriatrics from the Arctic and from the Oslo area in Norway. And I have a PhD in epidemiology from the University of Oslo, and I've been working on a postdoctoral project in autoimmunity at the Oslo University Hospital, where we also looked at T-cell surface markers using flow cytometry. So that's sort of a broad background, and I also have a Bachelor of Science in Economics from the University of Oslo. So, and I think that's why I'm here. I have an unusually broad background, but that has also given me the opportunity to decipher what's going on in the different fields here. And so I have been working during this pandemic a lot at fact checking, especially because there is this information overload, and unfortunately, some of it has been tainted by political, economics, and other motives, and it's just really, really complex and really hard to disseminate in good ways. So I'm really happy about this these projects. Anyway, I am focusing this talk on the handling of this heterogeneous and multi-layered information in order to facilitate the handling of the pandemic. But I will do it while discussing vaccine safety, efficacy, and role in the emerging variants. So it's a broad, enormous topic. Just get right to it. So 23% of the world population has now received at least one dose of a COVID-19 vaccine, and 3 billion doses have been administered globally. But as you see, there is a huge disparity here between different countries, and some have come really far, but are plateauing, others are still climbing, and some have hardly even got off the ground. So regarding efficacy, I have this table, and it's as you see, there is a red line across it, and that is on purpose. It is for you not to use this table because it can't be used in the way it is presented, but it presents the issues. So you have the different vaccines and the different vaccine types. And the 4 upper vaccines here are authorized by the European Medicines Agency. Pfizer and Moderna are mRNA vaccines, and then AstraZeneca, Johnson & Johnson are adenovirus vector-based vaccines, which also Sputnik V from Russia is. And then you have the Novavax, which is a protein-based vaccine. Very interesting results coming out now. And you have a couple of the examples of Chinese vaccines, Sinovac and Sinopharm. The Chinese vaccines are used in more than 90 countries around the globe. And you have the Covaxin about to come out of India. And so the thing is, how do you go about explaining efficacy? So you have to find when to test, after the first dose, after the second dose. Some of these use only one dose. So there's varying lengths after each dose. And there are all these different methodological issues here. So these figures are put up here for you to see, but you can't compare them directly because they don't represent the same thing. So I made this for myself, this table for myself when preparing this talk, but because I need to know, you know, but still there's a reason why you don't see it around. It's because you actually can't compare these figures. But still, I want to point to the last columns here, and I'm afraid one of them is actually partly hidden here. But there is a very high efficacy against serious disease and death in those fully vaccinated, and that is sort of a main take-home message. But the problem is they're different. These data come from different sources. Some of them are from peer-reviewed articles, government reports, manufacturers' press releases, WHO and other official sources. And there are different methods. You can use laboratory methods, clinical trials, of course, in the beginning, that's very important. And then epidemiological data becomes more and more important. But these are yield very different results. And you can choose different outcomes. You can choose different lengths of follow-up, as I mentioned. And the populations vary. You have different age groups. Some studies focus on the elderly or the young, and others exclude them. You have different comorbidities and different medication use in these different populations. And the populations vary between the different geographical areas, where you also have different prevalence of different ethnical backgrounds. Age distributions vary between different countries, etc. But most importantly here, you have also different variants in circulation in different places at the time of the observations. So, and the first time we saw evidence of this in scientific results during this pandemic was in February, when Mahdi et al. Released their report of the use of the AstraZeneca vaccine in South Africa, where they actually found only 10% efficacy. And the only thing I want you to get out of this figure, if you can see it on the right-hand side, is the extremely wide confidence interval, because these data are not, so 10.4, but anyway, you could actually see that there was not evidence of protection against symptomatic disease on the ground against that variant. And then this is happening. This is data from the UK, and these are not sequenced samples. And in the middle here, you have lots of different sequenced variants, and then the Delta variant comes. It's 50% more transmissible than the original, than the Alpha variant, and about 50% more transmissible again than the original variant. So it takes over. And that means the data you have here and here, where these studies, many studies were conducted, are not really applicable here, because you have more or less a different pandemic. The Delta has increased transmissibility, viral load, disease severity, increased risk of hospitalizations, less sensitive to neutralizing antibodies from recovered individuals, and unfortunately seems much higher risk for the young and unvaccinated going forward in this pandemic. So you sort of need to make a new table, and this is for the Delta variant, and you have to fill in the blanks, and you have the same issues here all over again. And what is noteworthy here is that in the first column, you have actually data pointing to much less protection after the first dose, of only 33% of the Pfizer and the AstraZeneca vaccines. Luckily, that increases after the second dose, but there is there is evidence now that there may be reduced effect in all of these vaccines, and maybe especially in some of these based on inactivated viruses, but there's much insecurity. But we have examples from Indonesia where fully vaccinated healthcare workers are infected. They have used Sinovac. And we have the Seychelles, where, as you can see, this almost 70% have been vaccinated. And Mongolia, where you see increase in cases. These are the increasing cases, and the Seychelles are on top here. And Mongolia, South Africa is increasing. Unfortunately, this also translates into the increase in deaths. So here you see the Seychelles. It's not very good looking. And then you see there's an increase here. So there's things happening, and we have to follow, and we have to need to follow the data here. So regarding safety, as I said, a lot of vaccines have been administered. We do have a lot of data now. Some mild side effects are very common, but serious side effects are rare. Anaphylaxis is comparable to other vaccines, so you just need to be prepared for that. Then there is the issue of vaccine-induced thrombotic thrombocytopenia that arose after, first observed after injection of adenovirus vector vaccines in the AstraZeneca, had also been seen in Johnson & Johnson. That is an immunological reaction, probably to the adenovirus vector, and it's seen in younger women. And it's a serious syndrome with quite a poor prognosis. So that has some ethical issues. And this the AstraZeneca vaccine has been taken out of use in some countries due to that. In Norway, this was a huge issue to start with, because we had the cases here. But there was a lot of transparency. And very interestingly is that so far in Norway, more than 90% of those offered the vaccine have taken it. And the maximum figure is in men age group 75 to 84 years, where 98.3% have had their first dose. So it does not seem to that these discussions have harmed have increased vaccine hesitancy. So very, very briefly, myopericarditis after mRNA vaccinations is also an issue. Seems to be more common in young male vaccinees. It is probably exceeding background rates. So it is probably a real thing, but this is also something we need to follow. The CDC and everyone else mostly still stress that benefit outweighs the risk. So the conclusions on vaccine safety and efficacy is that these vaccines offer good protection against hospitalization and death. The mRNA vaccines performance exceeds expectations by far. So that's a huge plus for us all. But all vaccines offer good protection against hospitalization and death. We still need lots of data for all these emerging vaccines. And as I said, there is an issue regarding Delta and all these other variants that are popping up, and sooner or later there will probably be yet another one or another one to follow Delta. So we need to follow that, and there are some safety issues on the adenovirus vector vaccines, some efficacy issues, maybe more on the vaccines based on the inactivated virus, but we need more data. And it's really important to stress also when communicating this, that the effects from vaccines for every person in real life will come both from the individual effect, which is what most of these studies now demonstrate, but also from an added effect from a population herd immunity that will arise after a while. So, and new variants will emerge that may even change this scenery again. So to conclude and to sort of bring into the discussion of this forum is going forward, from my perspective, studying this from as being like a scientist from different disciplines, I think it's really important to make sure that scientists communicate across disciplines, and especially that immunologists and epidemiologists get to talk and combine these data and to disseminate that knowledge. And one extra point is that openness may in fact prevent vaccine hesitancy. I will end by saying that we need data, and data must be made publicly available. And with that, I will leave the word for the next speaker to pick up on that. Thank you.
Gunhild, thank you. Thank you so much. That was a very, very interesting story and a very interesting perspective. I think we have some time later for the Q&A after we heard the presentation from the next speaker. So I will encourage people to leave your comments and your questions on the chat for Gunhild. So we are right on time. Now we can introduce Alejandro Rodríguez-González from the Technical University of Madrid, that will speak about big data applied to COVID-19. Thank you. The floor is yours.
Thank you. Hello, can you hear me well and see my screen in full screen?
Yes.
Perfect. Thank you very much. Well, first of all, thank you for inviting me to this workshop. It's a pleasure to be here and to talk about the opportunities and challenges that we have in using big data against COVID-19. First, I would like to introduce a little bit myself and my group. Well, I'm a computer scientist that has been working in the field of medical data analytics during, I think, that around 7-8 years, more or less. And I'm currently leading the Medical Data Analytics Laboratory, which is a research laboratory at the Center of Biomedical Technology at UPM. We have, in total, more than 20 years of experience in data analytics applied to several domains, including now the healthcare sector most recently. And our main areas are covering data integration, data analysis, NLP, and disease understanding as part of the project that we are developing. And you have here the information, the website of our laboratory for further information. I would like to start talking about big data, and I have this tweet from Dan Early from the university that makes a really interesting reflection about big data. And he told that big data is like teenage sex. Everyone talks about it. Nobody really knows how to do it. Everyone thinks everyone else is doing it, so everyone claims they are doing it. And I think that this is really interesting reflection, because when big data start as a, let's say, trendy topic, we had to deal with this problem of, are you doing big data or not? Are you sure? How do you know if you're doing big data or not? What is indeed big data? Let's say that the more formal definition of big data goes through the use of techniques, infrastructure, and algorithms that allows to process amounts of data that traditional, let's say, techniques or infrastructure are not able to deal with it. But of course, this changed over the years because we have more powerful computers, we have more data, and this is something that we need to consider. In my opinion, I think that the big data, well, probably you already know that the big data starts defining with the famous Bs, okay, with this volume, variety, etc. I think that now it's around 9 Bs. To be honest, I don't know the last two what is the meaning of them. But in my opinion, from these 5 Bs that I think that reflects the ideal, let's say, topic or things that are around big data are these 5, and more specifically the 5th one, that is the value. Because in my opinion, if we are not going to use the data in an appropriate way, we have like somehow a Diogenes digital syndrome, okay? Because we are collecting data and we are not using it. So I'm going to focus my talk moving from big data to this topic of machine learning and artificial intelligence, because indeed the idea of big data in terms of using it and getting some value from it goes through the analytics that it's made normally by statistical approaches or machine learning or artificial intelligence techniques to make decisions. And this is the important topic, and this is the important part in the handling of the large amounts of data that we have nowadays. Going to the topic of COVID-19, I would like to start with something that was described at the beginning of this workshop, and is this infodemic. I completely agree with this approach. We not only have a pandemic, we have an infodemic, and this is something that we can see in the number of scientific publications that has been published during these 2 years, more or less, of pandemia. And the efforts that has been done, for example, like COR19, there is the COVID-19 Open Research Dataset to collect all this information. Indeed, the number of papers that has been published is so high, as we can see in this letter published in Nature, that around 4% of the world research output in 2020 was devoted to coronavirus, okay? Which is something that is really important in order to see the magnitude of the amount of data that we need to deal with. And here is where we need, again, for example, this example of artificial intelligence. This is a paper published in Briefing in Bioinformatics that analyzed the use of text mining approaches, which is, let's say, one branch of artificial intelligence, the one that is in charge of processing text, in order to deal as much quick as possible with this large amount of information, okay? So in the topic of big data and COVID-19, one important key is the number of scientific publications that has been published, which sometimes makes even difficult to be updated or up to date of all the information that or all the knowledge that we have. But it's not the only thing that we need to consider as part of the current situation. Another one that I think is really important and indeed will drive my next slides is the patient data. Now we have, I write plenty. I don't know if plenty is the best word. We have some resources with data about COVID-19 patients. Indeed, we know Hospitales de Madrid, which is one of the partners of unCoVer, that has this data set, COVID Data Save Lives, that allows the researchers to work with the data from real patients, or the COVID-19 research database, or the COVID-19 data portal that allows to get information not only from the patients in terms of the clinical information, but also, for example, genetic sequences of the samples that were taken from those patients, etc. And this is like the situation right now. Now, what are these opportunities and these challenges? Well, the first thing is that this is the, let's say, main general picture that it's able to summarize the opportunities and the challenges that we have in big data applied to COVID-19. So on one hand, at the left side, we have the COVID-19 data sources that includes these patient health records, medical imaging, infected case history, information about the outbreaks in certain areas, as well as the scientific literature that I mentioned, that is not in this image. On the right side, we have the applications of big data over this type of data, or the combination of these types of data: outbreak prediction, spread tracking, diagnosis, or vaccine drug production. And in the middle, we have the process that is basically generate the data, acquire it, and storage, and process it or model it in order to make this big data analysis. Again, I would like to emphasize that my approach of big data here is the analysis in order to get value, because if not, it's not sense, but it's probably not the best solution. And I would like to start showing some examples about these opportunities that we have. In the context of diagnosis, there are like two or three types of approaches. One has been very focused on the medical imaging side, and basically the idea is process or create model from medical images, in this case X-ray and CT scans, and being able to predict if a patient is going to be a COVID-19 case or a normal case. This is something that allows to create somehow a different diagnosis perspective more than, for example, the test that we are using nowadays, like the PCR or something like that. In this case, it's using an approach based on neural networks. We will see that indeed more specifically it's on deep learning, that it's a new paradigm in the uses of neural networks that allows to train a model, okay, with this information and being able to create a binary classifier that allows me to see if it's positive or not. In the same context, we have, and this is just another example that use basically the same. This is a paper published in Nature Medicine that use the same information, the medical imaging, plus some clinical data, laboratory data, as well as exposure history. And this exposure history, for example, is really interesting because it has been used in another case that I will show later in Taiwan in order to, let's say, compute the likelihood of a given potential patient of being infected by COVID-19. And this is something that is interested in order also to calculate potential new outbreaks in a certain population. And in this case, the idea is, again, trying to make a rapid diagnosis. And this is another paper that, well, basically is the same idea. It's just to give some examples. It has been published in Computers in Biology and Medicine. And in this case, using the X-ray images, they are able to create a deep learning model that allows to identify a potential diagnosis. All these cases are really interesting, but I will talk later a little bit about this. In terms of fast response, I saw this paper published in JAMA, in the Journal of American Medical Association, which is really interesting, and it's about how in Taiwan they use the concept of big data to have a fast response about the COVID-19 spread. And the idea basically is that they were able to, using different types of information, like, for example, traveling information of a given passenger, where he or she came from or where he or she goes to, and maybe the middle, let's say, steps, trying to get in this information as well as clinical history that includes the symptoms, calculate the likelihood of having a potential passenger that can be infected with COVID-19 and do the appropriate tasks. Another example is that they use, for example, the information that they have a national health insurance, to retest all these patients that were tested as negative in influenza to try to detect if they were positive, for example, at COVID-19. In this case, well, let's say that the percentage of accuracy was not very high. Only one of 113 cases was found. The next topic that I would like, or the next opportunity that I would like to emphasize, is the drug repurposing. Drug repurposing is, the idea of drug repurposing is trying to find new use to drugs that already exist. Probably we already know some famous cases about this. There are two that I think that are really famous. One is the Viagra, that probably we already know all, that was intended for hypertension and cardiovascular related problems, and now is used for erectile dysfunction in males. Another that was sadly very famous was thalidomide, that was used for nausea and vomiting in pregnant women to reduce this nausea and vomiting, but this drug caused phocomelia in the babies, and now is used for leprosum erythema, okay, to be used for the leprosum erythema. So are two drugs that already exist. And drug repurposing is a really interesting topic because it allows to reduce the number of the number of years that takes to produce a new drug, as well as the cost associated. I would like just to show you, and this is one of our own research. We have a project that is called DisNet that basically, to summarize very quick, what we did is we use information from phenotypical data, symptomatological, biological, in this case, genes and proteins, okay, and drugs that we get from the drug bank. And what we create is a set of paths that allows us to see the similarities between different diseases according to this biological information. This is research that we are waiting for the final approval in drug discovery today. And what we found is that we were able to find 13 candidates that were indeed tested in clinical trials. Some of them are ongoing, some of them were discarded, and but were candidates that were able to retrieve from a computational perspective. Of course, this needs more work, focusing on in vitro analysis. That is something that, of course, we cannot do. We are a, let's say, computer science laboratory. But the idea is that we were able to find these potential drugs that can be repurposed for COVID-19. And in terms of the opportunities, to finish with this part, and yeah, I would like to mention the COVID-19 High Performance Computing Consortium from IBM, that it's a consortium that allows to use HPC or high performance computing to create several types of projects that requires large amounts of processing. And there are some projects there, like, for example, trying to find antiviral drugs or trying to get mitigation and response projects from the data that they have. Now, very quick, and just to finish, I would like to go to the challenges. The challenge is one of the first, and I would like to mention it with one of my previous slides, is that we have a lot of information, we have a lot of hospitals, clinicals, etc., that they have data that is worthy to be used in COVID-19, but we cannot transfer this data due to GDPR, etc., etc. And I would like to mention this unCoVer aspect that is, this aspect of unCoVer that is developed right now by UPM, that is basically the idea of having all the data available from a client perspective without the necessity of transferring the data from one institution to another, allowing to retrieve the relevant data for a given research without the necessity of doing a real transfer to an intermediate point. And this is something really interesting because also allows to comply with the GDPR legislation. And well, regarding with that, another challenge that we need to face and still deal with is the privacy. We probably all know all the problems that were in a lot of countries with these applications to track the COVID-19 and the contacts and all this stuff. And this is something that is mainly a technological problem, but also a privacy problem. And it's another thing that we need to deal with because it's really important. And finally, to finish, the most important one for me, this is a tweet that was published by Eric Topol that maybe you know him. It's a medical researcher that is very focused on digital health. And he published this tweet analyzing a paper that was published in Nature Machine Intelligence, where the authors did a study of more than 2,000 studies that create artificial intelligence models based on medical imaging, as I explained at the beginning, and they conclude that none of the models are of potential clinical use. And this is something really important because, we can do a lot of research, we can do a lot of artificial intelligence things, but what is the point if we are not able to clinically use them because it's biased and we are not going to create something that at the end is going to be used? We need to do this in a proper way in order to transfer the technology from the research to the clinical side. And that's all from my side. Sorry if I go a little bit over time. Thank you very much.
Thank you, Alejandro. That was also very, very interesting talk and all the opportunities and challenges, and nice to see that you back up the approach that unCoVer and UPN is taking on sharing the data across the different partners. I see the chat, and I hope that I'm seeing the current vision of the chat, and I don't see any questions. So I would like to ask if anybody has any question or comment. While you think about it, I was wondering when Gunhild was telling us about the efficacy and the safety of the vaccine, and how we have to remember the context where the vaccine was studied. So in the context of the trial, and the trial within the study population within the trial. I was wondering if you're aware of any finding coming from this big data analysis or real world data on the effectiveness and safety profiles of the vaccine that can add into what we know about the safety of the different vaccines that we have available now.
I think you have to specify the question. You're thinking about the methodological approach about with big data, if they have, if it has uncovered like specific problems or issues. I
wonder if there are data out there that can be compared with the efficacy trials, but coming from effectiveness trials. So whether the efficacy that it's seen in the trial is replicated or can be replicated in real patients reporting, for example, safety events at the hospitals.
Regarding big data?
Yes.
Yes. I'm not aware of any research into vaccine efficacy that has utilized big data, actually. Maybe maybe Alejandro knows of any?
To be honest, I think that there are some things around big data and vaccines, but there is not too much, because in contrast with drug repurposing, which is a more, let's say, aspect that can be computationally addressed, I think that in the development of vaccines and in the comparison with the efficacy, probably there are something. Again, this is the problem of the infodemic. There are so much there that probably it's difficult to know, but I didn't see too much neither.
Yeah. But it's a very interesting, very interesting question. Yes.
Alejandro,
so sorry, David, go ahead.
No, I just had a question for Alejandro, because I was going to ask if you would agree that there are so much information about big data and unCoVer that some of them is not useful for clinical use. And then you just finished with that tweet from Eric in which that is exactly shown, that all the models or most of the models are not yet of clinical use. Do you have any opinion on what are the problems of these models? Is it the quality of the data? Is it the data cleaning? Is it the architecture? I mean, why cannot these, I know this is an unfair question, you cannot know all of them, but what would be the most common problems with these big data-based models that make them unusable in a clinical set?
Okay, well, that's indeed a tricky question, but it's really interesting. I mean, I think that there can be many problems, but one of the things that I always talk with my students is that, I mean, we cannot focus on just aspects like accuracy to evaluate models. This is not the appropriate way of evaluating a model, a machine learning model, because when you are evaluating a machine learning model, you need to take into account several other things. And at least I read several research done about COVID-19 or any other disease that they focus too much on this. And I think that they are not appropriately evaluated. And I think that other, let's say, less biased evaluation metrics needs to be performed. So I think that this is one problem. Another is, of course, the data. I saw many studies also with a lot of unbalanced data and with models that were created using this unbalanced data without the probably appropriate techniques to address this issue. And this can cause a problem in the model final, again, accuracy or, let's say, how it is behaving. So I think that probably is a mixture of things about the data that they have, as well as how these models have been evaluated.
Yeah.
Very good. We have a couple of questions in the chat. One from Kirsten asking about the feasibility of imaging processing within Data Shield, within the sort of the operational part of the federated data platform. Maybe Alejandro, you can comment on this.
Well, this is something that is now still under development as part of the unCoVer platform. As far as I know, in the context of structured data, it is something that, it is the case. To be honest, in the case of the medical imaging and the medical data, since it's a more complex approach of data, I mean, the data itself, the nature of the data is completely different from structured data when we have, for example, tables, let's say, okay, or even in textual data. This is something that, to be honest, I would like to check, because I'm not completely sure how it fits in the medical data, in the medical image data. Sorry.
Indeed, might be difficult, because this imaging processing goes through different algorithms that might be difficult to integrate in the platform.
Yeah, that's the point there.
Elena Musi is asking you, Alejandro, about leveraging big data for risk assessment, and in the example of AstraZeneca. You have an opinion on this?
Again, tricky question, very tricky one. Well, I mean, I think that this, at the end, the concept of big data can be used in several domains, and risk assessment, of course, is one of them. Well, I mean, I'm not very fan of talking when it's very outside of my expertise. I think that is something that, of course, is possible in order to, let's say, have more clear policies, because we saw that in the European Union there were very different policies in the use of AstraZeneca. I don't know how much this influences indeed by, to be honest, and probably you will talk about this later in the second part of the news, and how this influence on the population in the terms of the risk that they perceive about this. I mean, about some kind of vaccines. But I mean, I'm not sure how this can be assessed from the big data perspective. Of course, that probably can, okay, but I think that it's a little bit out of my field, and I don't want to give a more extended answer, because probably I'm not the best expert in this.
I think indeed there are challenges in the use of big data, and also in translating the findings from big data analysis into the general public, because they are not quite straightforward. I see a comment from Herman van Ooyen from Sciensano, saying that we will probably have to go back to basic epidemiological question and access of bias in applying these big data techniques, which is probably true. Herman, feel free to jump in if you want to comment further.
Yeah, it's independent if you're using this type of analysis, because it's only one approach to look at data. But the most essential question is that we have to look at, and that's, I think, is what's often forgotten when people put in information into either publication or social media, is that they have really to think about what is the selection bias, information bias, and for safety or for side effect of vaccine is exactly the same. And we have really to understand how the different, for instance, administrative or ministries are working when they're collecting those type of data, and how those processes are done or then working. And that, I think, is also very much essential, and in the way that we as scientists should be working. So we always have really to keep those things into mind, yes. And that will be very helpful in our assignments, yes.
Thank you, Herman. That's a very good observation. Is there any more question? I don't see hands up or anything on the chat. So I propose to save maybe some more questions towards the end of the session. We'll have another Q&A session and continue with the workshop now. I will ask my colleague Petronille to take a short break. Is that what was
I thought that would be a very short break, but I'm happy to also keep on going. So up to you, Jose.
Oh, I will say, let's just, because we are a little bit early, let's just take a break.
Yeah, we can have a 3 minutes break, perhaps, and then start on schedule. It's in 3 minutes, actually.
Wonderful. Thank you so much, David.
Thank
See you
you.
in 3 minutes then. Thank you.
Sounds perfect. Thanks, everybody. Thanks.
Well, you drink champagne and it tastes like Coca-Cola. Cola. She walked up to me and she asked me to dance. I asked her her name and in a dark brown voice she said hello. Hello, Elena. La 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 la.
All right. I hope everyone enjoyed this very short musical break. I think it's always nice. Music brings people together and allows you to just move a little bit around, stretch your legs when we have a short meeting. All right, so let's keep on going. This wonderful workshop. Thank you already so much to the speakers we have heard until now. I think the conversation is very interesting. And then I see our next 3 speakers have already turned on their video so you can see them. The first person we will be hearing is Hernando. Hernâni, sorry, excuse me for the pronunciation. He's been working in Bright, a startup oriented to the development of technological solutions to increase therapeutic adherence. He also has a background in biology and communication science and a master's degree in oncology. And he worked as a science and health communication researcher on iTunes, Year Project, and the Madeiras Chemistry Center, and at the Sports and Medicine Research Center from UTAD University. So thank you so much for joining us today. And the topic of the discussion, or the name of the presentation, will be Do's and Don'ts when communicating scientific information to the public. So very exciting to hear about that. Hernâni, over to you.
Thank you so much. I'm trying to, let me see if I can share with you my presentation.
No problem. And I hope I pronounce your name correctly.
Yeah, it's Hernâni. Yeah, it's
okay,
fine. It's
perfect.
fine. Totally fine. It's very difficult. It's not a very common name. Yeah, so let me see if I can. Are you seeing it now?
Yes, we can see your screen.
Okay, fantastic.
Wonderful, full screen, perfect. Go ahead,
Yeah.
the floor is yours.
So I know that many of you are scientists like me. Today I'm going to try to talk about some kind of examples that we witness on a daily basis, not only on COVID-19, but I try to, I hope this is not going to be so theoretical, but also practical, with practical examples. But I would like to say that it's very important, and COVID-19 showed us the importance of communication. We had a lot of waves, not only about numbers, but also about information that came to us, and we were not prepared for this wave of information. And that's why we heard a lot of about infodemics now. And I'm not going to talk about infodemics. I'm going to try to focus my slide in my presentation in some of the do's and don'ts and practical tips for you when we try to speak about your science. And these infodemics happen because of the multiple channels that we have nowadays. Multiple channels means multiple sources, and the disparity of the discourse was overwhelming. And we had new public opinion perceptions about a new thing, a whole knowledge about viruses, but a new thing, a new virus that we don't know how to behave. And so there was a new public perception about this new idea of a new virus. And there was an excess of news, an exhaustion of news about COVID-19 on the news, on every single platform, and social media impacts helped to transform these infodemics in a truly problem about how the communication is done in terms of science communication and in terms of risk communication. So today I would like to address the topic of risk communication. And because we know now that infodemics, and this is a really cool article I can share with you later on about how infodemic works. And we have two kinds of disseminators of information. We have the human kind, and we have the bot kind. And I think we are going to talk about this later on. But we know that new technologies are helping these infodemics working with, which is could be a knife. When I say knife, is that we can use a knife for good things and a knife for bad things. And artificial intelligence, like we have seen, is very cool. We can use that, but nowadays it can use to the worst. And infodemics is one of the examples. And we have the human kind that can spread this truth, or they can share something that is not true, and something that is going to worsen the panorama of how to deal with a pandemic. So today I would like to talk about uncertainty. When we talk about risk communication, we are talking about uncertainty, and we are talking about danger. But we should focus on trust, and we should focus on health literacy. These are my two biggest words for the year of 2021 for me. Trust, because when we are communicating health, we are doing politics. I don't know if you know this, but health means politics now. And for communication, for media purposes, we are always seeing health in the politics department or the society department, editorial department, that I'm talking about that. And so we have to know that when we try to talk about politics, and when we try to talk about communication in politics, we are focused on being assertive, being right on point, and uncertainty is not part of this communication in politics. That's why an epidemiology is an epidemic is very difficult to share. It's very difficult to communicate because politics and because people don't want to say that they are uncertain about things. So we need to build, based on this uncertainty, we need to build trust on the communication, on facts that we already know that are true. And danger, because we know that there are some kind of danger for these people, for humankind, and we need to, based on the health literacy that people have, we need to build more and more efforts to try to manage this situation. And we have different levels of health literacy. We have different segmentations of communication, and we need to address all these different levels. I like to use this analogy when I speak about health literacy or scientific literacy. Imagine us, like scientists, we have by theoretical approach, we can have a health literacy level or a scientific literacy level above the mean of the population. We know that that door, unless you are daltonic, and sorry for that, it was not on purpose, but we are seeing a yellow door. We know that the yellow door is the right decision to have. It's the right decision to have better results for my health. So we distinguish the bad from the good. We know which which door to open. We are going to open this door. We don't know, because some of the mainly attitudes that we have on a daily basis are based on automatic decision processes. So we do things automatically. So we need to educate people to try to transform this automatic process in a non-automatic and a process that is going to be, we think about them, okay? But we are not sure that people are going to open this door. This is for people that have a high health literacy or a high scientific literacy. So imagine this. For people that don't have this literacy, they see a lot. And this is an analogy. I know that it's true. I'm exaggerating, of course, the reality, but sometimes it's like this. We have different patterns. We have different ways to follow, and sometimes we don't know which is the right decision for us. So we need to inform people what is the best option, and we need to realize that we need to do that. Okay, this is the importance to consider the health literacy level of people when communicating with them. So I'm going to use the rest of the time that I have to explain some do's and don'ts of science communication and risk communication. First, when you are a scientist, just try to be open and available to talk, even with media. I have lots of colleagues that don't want to be interviewed by media. You can also try to say to them, look, I prefer to email me the questions. I can answer you by email. Protect yourself if you don't want to be open, too much open for this media approach, but be open and available for them. Don't shut the door just because we are not comfortable with communication. The second one is know your audience. We are talking for whom? Who is your audience? And one of the best thing to know your audience is try to create a persona. A persona is kind of a character with characteristics of your audience, with a name, with an age, with capabilities, with pains, and try to use that to identify your audience. It's very, very cool. Engage with the public. Don't be afraid to do that. Don't be afraid to open your heart, to talk with them, to say, look, we know for sure that this happens in science, but we are trying to work hard to know more about this, okay? And try to simplify your explanation. Sometimes it's very difficult when we talk about science to simplify things, because we know science is complex. We want to declare this complexity of science, but we need to be, look, we need to I'm going to, and you can say, I'm going to explain this in a simple way, but this is much more complex. We have some variables that we have to consider here. It's not, we are not trying to create some sort of, this is a generality or a general truth. We need to consider other variables for this, but try to simplify. To simplify is not to being simplistic. Use the power of the image. We are seeing one project that I really like, that right, it's not on COVID, it's in cancer. Nowadays we use a lot of jargon when we communicate with people, and this project tried to communicate with women with cancer just only by using infographics that combines little text with no jargon with images. These images were produced based on photo reports from real spaces like hospitals to guide these patients. Bring in other stakeholders. Remember, you are not alone, and people need you and need your information. So don't be afraid to share your thoughts, organize events with municipalities, museums, libraries. We need, and regional media is very, very important. We need that. Illustrate your use of numbers. If you are going to give numbers, try to compare these numbers with the size of the country. For example, if you are saying you are using space, compare with the size of a country. If you are saying the amount of people, compare with the number of people of a country. And try to not use not very common units, or try to explain them if it's not very common. For us that we are dealing with this on a daily basis, it's very difficult to know. This is, people know this, so try to question people that are not in your field and try to know what is their feedback. Contextualize. We need to remind people on risk communication about one risk that is a new risk, and compare this with the risk that a human have on a daily basis. Okay, this is going to normalize the risk of the new risk, and is going to put in perspective this, and this is very, very important. Always present risks in relation to benefits, and vaccines are one great example, and we were not able to do that. And do not always remember, try to report your data, but try to report always the lack of data. Even the lack of data is a data itself. So it's an information itself, it's communication. Try to do that also. Be a human, don't be afraid to do that. Don't be afraid to connect with people, to try to say, look, we are trying our best. These are my options. We are trying to listen to the public concerns. We need to listen to that. And use narratives, use stories to tell. We can use stories that people know, movies, we can use the history itself, and we can create our own story. People engage much more, if we try to have a point A, a point B, a conflict, and we are dealing with the conflict is the main message that we want to share, and try to transform your communication into something entertainment, and something with the entertainment, and something very cool to listen about. I think we are running against of time. I just want to share with you one example. Yeah, I know. Sorry. One example of this. We are now in Portugal using science and scientists to create a transmedia and participative campaigns for people. We are using outdoors of the municipalities. We are using animated videos. We are trying to put scientists writing with us scripts for these animated videos. We are using people, famous people, to convey our message, and we are involve people in this participation. We are enrolling students and try to have this approach. We need always, don't forget, a meaningful and target communication. We need to identify our own message, our prior message, and we need to have clear messages. We need to have all of that in order to build trust. And that's one of your main missions as scientists. Thank you so much.
Thank you, Hernâni. Very interesting. There are already some questions that pop in my mind, but I will take the opportunity to say to everyone, please just write your messages in the chat and we will take them during the Q&A. Because first we would like to go to the second speaker. Actually, it's two colleagues that will be speaking. We have Elena Musi and Elinor Carmi. So first we will be talking about infodemic management and building resilience to mis and disinformation. So I think this will really nicely fit and find synergies with the presentation we just heard. And then we will go into breakout rooms, into smaller groups to talk a bit about FakeNews Immunity chatbot. And so this will do in breakout rooms. And then we'll reconvene together at 15:45, so 2:45, to have the Q&A. All right, so over to our colleagues, Elena and Elinor.
Hi, thanks for having us. So during the first 10 minutes of our slot, we will quickly present the result of the research project Being Alone Together, Developing Fake News Immunity, which is a project funded by ESRC UKRI, and it's in collaboration with the University of Dundee. So this project, as Elinor will explain us, actually focuses on misinformation, so rather than disinformation. And misinformation, actually, it's very challenging to be identified right now by automatic fact checkers. So yeah,
maybe we just introduce ourselves, Elena first. So I'm Dr. Elinor Carmi. I'm a postdoc researcher at the University of Liverpool. I'm working on me and my big data, developing citizen-style literacies, and I also have a fellowship with the UK Parliament with the DCMS committee around digital literacies. And Elena, you want to present yourself?
Of course, yeah. So I'm Elena. I'm a lecturer in artificial intelligence and communication. I also worked in industry beforehand as a computational linguist building Amazon Alexa. And right now I'm PI on the project where I'm working together with Elinor and another quite big research team with the goal of fighting the infodemic.
Fantastic. So this project, which we started in May last year, talks about where we basically managed to develop 2 chatbots. We're going to play with you shortly, but we just want to present sort of what we've come up with so far. And as you can see here in the online manipulation ecosystem, and I'm sure that a lot of you are already familiar with this different kind of definitions, but it's important for us to emphasize that we mainly focus on misinformation, which is information that is misleading, but not created with intention of causing harm. Next slide, please. Great.
Yeah, sorry, I actually changed slides. Can you see it?
Yes, now I can see it. One of the main issues with misinformation, though, as you can see here, that misinformation consists of reconfigured misinformation, which means that a lot of the things that we're seeing is partly true and then partly not true, which means that it makes it very difficult for people to identify what exactly within that context is true and what is not true. And that creates a lot of confusion. And this is where our research comes into place. So
yeah, apologies. I just changed slides, but it seems it's not completely synchronous.
No worries. Do you want to continue or do you want me to go?
No, if you can see these slides, my connection is slightly unstable. I'm sorry for that.
All right, so maybe.
So yeah, can you see the slide with like our goal?
Yeah. All right, so I'll just continue. So our goal basically is to reverse engineer the manipulation of information, providing citizens with the means to act as fact checkers and communication gatekeepers with basically the means to avoid creating and spreading misinformation news. And the way that we do that, as Elena said, we are a really big team that combines people with different kind of specialities. So we come from critical thinking, sort of data literacies, fallacy theory, and human-computer interaction.
So what is fallacy theory? You're probably all familiar with what critical thinking is or like might be, and human-computer interaction too, but probably not with fallacies. So why are fallacies useful? Well, fallacies are arguments. As I said, we all know that fake news are news that seem valid, but are actually not valid. So the theoretical assumption behind is that fake news are likely hosts for fallacious arguments, which in practice means if you're able to identify fallacious arguments in a news, it's really high likelihood that you will be also able to flag fake news. In order to test these hypotheses, we collected through web scraping a corpus of 1,500 like from January 2020 to end of June 2020, and also from January 2021 to the end of March 2021, since we wanted to capture also news related and focused to the vaccine to see whether there would be differences or not. Very briefly, so the research pipeline that we followed, we collected the data, we went through a phase of data annotation and evaluation, we analyzed the results, then we selected the most popular cases in terms of misinformation. So with popular, we mean those that were like shared the most across social media. And then we developed 2 chatbots that we will present shortly, and you will be able to play with one of those. And we are in the process of evaluating them right now.
So one of the key sort of insights that we figured out from analyzing all of the fact-checking websites is that one of the main sources of misinformation is surprisingly from governments. So governments a lot of the times distribute information that is very misleading, and it's very problematic for people to know whether it's truthful or not. And that's really important because we usually tend to trust what governments sort of communicate to us. So this is why with our chatbots, one of the main things that we wanted to do is to help people who are, working in the media industry or work as media gatekeepers to communicate information in a better way. Next slide, please. And another thing that we discovered that according to the 10 fallacies that we have, and again, if you want to download the booklet that we produce with different kind of libraries in the UK, feel free to go to our website, which I posted in the chat. And in there, you would be able to see the 10 fallacies that we've developed. It's free to download, it's a PDF. So from our analysis, we discovered that this kind of the 3 main fallacies are cherry picking, evading the burden of truth, and hasty generalizations. Next slide.
Okay, so right now a brief presentation about the, sorry, it's not synchronous, unfortunately. So let's jump onto the chatbots themselves. And so first of all, what are we doing with this chatbot? What are the audiences and why are they important? So we built 2 chatbots. The first one is the FakeNews Immunity chatbot and is meant to be used by citizens, so whomever, without any specific knowledge about digital literacy or media literacy. And as you can see probably through the description of the chatbot, so there's also, it's a gamification environment. And why so? Well, education sciences, they tell us that gamification are very fruitful environment to teach in general. And especially right now that, of course, people are, bombarded by digital media. And so it's also very difficult to keep up attention. And through gamification environment, you can fail as much as you want, first of all. Second, you will receive, as you will see, very rapid feedback, since our chatbots are multi-agent chatbots. So you play and you talk with different participants. And of course, also there's a storytelling. In our case, the storytelling boils down to ancient Greece, where like the fathers of fallacy theory come from: Socrates, Aristotle, Gorgias. You also have like different stages and levels. So there's this idea of progress while playing. The first, in the FakeNews Immunity chatbot, you are credulous, or you can be a skeptic, and finally you become an agnostic before becoming fake news immune. The second chatbot, which is the one we are going to try out like today, is the so-called vaccinating news chatbot. It came out not long ago, around less than 1 month ago, and to write news that are non-misleading, because as Eleanor was saying, the main issue is that even though there's not the intention to actually spread fake news, sometimes this just like happens in uncertainty scenario, as Hernâni was pointing out. And so through this chatbot, you can learn how to write non-misleading headlines and also how to write non-misleading articles in general, or how to transfer like a news editorial, for example, being necessary without being misleading. So without any further ado, I'd suggest to start playing with the chatbots, and then we can discuss what was your experience with them. Eleanor just typed in the link to the chatbot, and I suggest we can create breakout rooms, and in each group, one person might just like share the screen, and then you can go and play with the chatbot like together, and then we will reconvene and briefly discuss the experience.
Yeah, and I think like what we really want you to do, one of the main things, this game can be played alone, but it could also be played with other people. And this is what we really want to encourage, how you can identify this together, or if you have different kind of insights or things like that, we would really love to know. So the link is here. And the best way would be after you're going to be divided into groups of maximum 5 people. You can play with that and talk about, what kind of things you discover. And then we can reconvene, as Elena said, and we can see what are your kind of key issues and insights.
So we are going to create the breakout rooms. People will be sorted randomly, but please open the link before, because once you are inside the breakout room, you may not see the chat as it is now. Okay, so we are going to create now the breakout rooms.
Thank you so much. All right, we reconvene in 15 minutes. See you all soon.
Yeah,
in
15
minutes
minutes.
again.
Thank you.
So welcome back, everyone. I hope you really enjoyed your breakout session, and I hope you played around a little bit with the chatbot. Any reactions? Anybody wants to just share a bit of their experience, what they thought of the exercise? Maybe I can pick on someone. In my group, Ninka was leading a bit the discussion. So Ninka, do you want to share on your experience of using the chatbot?
Yes, thank you. Actually, this was not the first time for me using this chat box, but actually it keeps being so entertaining, especially because you can ask all the other philosophers for some tips and tricks. But what we really liked in our group is that it really links to websites that are actually out there. We started first with an article on the Daily Mail. We went on Twitter. We went on Facebook, and actually seeing this happening in the real world was super useful, because normally you wouldn't think so clearly about all the fallacies, that, for example, that are being used. So that was a really nice experience.
Thank you, Ninka. Anyone from another group who would like to share some views? Maybe group 2 or group 3? Did you enjoy using the game? Yes, Alejandro. Go ahead.
Yeah, sorry, I don't know exactly which number I
That's
was.
fine. Just go ahead. Take the floor.
I just want to mention that it was a really interesting tool. Yeah, I think that it's quite informative. I was commenting that I think that it allows to, well, apart that I really like the idea of the fallacies, that I mean the type of fallacies that are behind each type of message. I think that also on the idea of having this feedback about the type of content, and also that it can be focused, for example, on the type of post on social media, or if you are going to write an article that are different types of communicating, and each one, of course, has different characteristics in communicating. And I think that the chatbot there can help to let's say do a proper or a better communication. So just congratulate for the work.
Yes, that's true. It's really nice how we combine the different platforms indeed, and it provides you also some good tricks on how to be more sensitive to what you read and what is out there. Any more remarks or comments on the actual game? Yes, Miriam, and then I go to Orla. Go ahead, Miriam.
Yeah, I also had a similar experience to Ninka. I had the opportunity to already try the chatbot, but today just our path followed, like we followed a completely different path. So we really had different examples, and it was really nice to also have examples that many people were talking about. So we had example of the side effects of the Pfizer vaccine. It would cause infertility in pregnant women. So we know that was a really relevant topic in the news. So it was really nice to see how like the topic has been framed and different ways you can talk about it. So again, it's the second time I played a game, but it was again really informative because we could just choose a different topic. So I really enjoyed it.
So it's nice to have the variety, indeed. Orla, do you want to say a few words?
Yes, I would actually echo everything that has been said so far. This also was not my first time playing the game, but our group was wondering like how is this game imagined to like be disseminated? Like who is the target audience really? And what would be, how do they, how do you imagine using this going forward for maybe vaccine hesitant audiences or maybe in a media literacy context? We're just quite curious about that.
Great question. Eleanor, would you like to take that one?
I can say a bit. I think for us, one of the main things is that we wanted to deal, with this specific chatbot, we wanted to address people who work in the media industry, but also are, media gatekeepers. So that could be journalists, editors, PR people, people who are working on the social media. One of the main things, the problem with the social media economy is that a lot of journalists and editors are looking for clickbaits, right? So a lot of the way that they frame and create different kind of titles are very misleading on purpose to create more clicks, and that is very problematic when it comes to a pandemic. We also wanted to address people who are working, in health authorities or in councils and things like that, because we really feel that there's a lot of people who are communication gatekeepers. It could be also, people in your religious places. It could be, in your church or in your temple. So we ideally would, want to communicate with those people. I know Elena has already had several presentations with, health authorities, and it's really important for people to realize how, how crucial it is to communicate in an efficient way and in a way that doesn't communicate misleading types of information. Maybe Elena wants to add as well.
Yeah, more on the dissemination aspect, I guess. We had like workshop with Public Health England, or also, Sefton Council, which is the council surrounding like Liverpool, and just like, to spread it out. Of course, there are two caveats. First of all, you might think, well, but the cases are time sensitive, right? It's true, but the idea is that learning these kind of like skills and being wary of different types of fallacies, something that then it's a critical thinking you can apply also to different contexts. Second caveat that we actually hope to solve somehow is the language, because right now the chatbots are in English only, which cuts out, of course, lots of people. And so we hope we will be able to translate. And of course, in that case, also the type of news needs to be updated, because recent research has shown that in different countries and different cultures. For example, vaccine hesitance arguments change too. So
of course.
there's
Thank you,
still a lot of
Elena. I actually still have a question for both you, Elinor, Elena, and Hernâni. So I will ask my question, and then I see your hand is up, Hernâni, so I'll give you the floor after. So my question is, regardless of, it seems, the health literacy level, misinformation seems to really impact everyone, and even maybe highly educated people or people with different backgrounds are exposed and vulnerable to it. Why is that? And first I'll go to Hernâni if you want to make your comment.
Yeah, sure. So it depends on the source that is disseminating it, and I want just to say something first. This chatbot would be very interesting for journalism students that are learning how to write, how to organize their thoughts when writing a news. And this is somehow related with this question. Sometimes we have this knowledge about health or about literacy, but we can't interpret text really well. So we need to know how to make the information clear for these cases. Another thing is that this kind of chatbot or this kind of technology would be very interesting also for people inside the health communication offices within the health literacy authorities and health authorities, because sometimes we just gave them the press releases and they copy paste the press release and put in the news. There are no sense of let's try to change it. So I guess this is a really good topic to address now. And in terms of health literacy, it depends on the source. Maybe we need to educate better our sources, try to implement better ways to simplify the message. Because sometimes it's a very complex world, the health literacy world. It depends on, in some points, some beliefs that are not scientific, and so it's very complex to address. But yeah,
thank you, Hernâni. Elinor, any final words?
I just want to add that I think with like every new pandemic, I think even with AIDS, because people just didn't know anything about it before, it's much easier to sort of to spread misinformation because people just don't know anything about it, right? We discover as we go along still with the COVID-19 pandemic. And that creates an issue. You said, you know, people who are very literate or people who are, you know, have a high level of education, that creates a big, you know, problem because it's easier to convince people about these things. And as we showed before, the main misinformation actually comes from governments and the broadcast media, which I think traditionally most people actually believe in, so, and trust. So I think a lot of the times that means that you need to make more actions to verify information, right? I need to go to the trusted sources. I need to make more actions. And a lot of the time people don't have the time or resources or, you know, different kind of things. So this is, I think, the main issue. Maybe I'm sure Elena has more to contribute.
Now, very quickly to add on that, interesting also, the Oxford Internet Institute found out that infodemically vulnerable people, so the percentage in the UK increased during the pandemic. And that's because also the affordances of different digital media, which is like where we source all our news right now, people become, since they are bombarded by information and also they can't have like face-to-face experiences, I think there's a radicalization of danger that we, in terms of like infodemic, that we really need to address.
Yes, thank you so much. And I think also one point on that, in some of the other talks I've heard about misinformation and pandemic management, they actually said that the amount of misinformation on social media didn't necessarily change that much, but the topic extremely changed, and it all focused on COVID-19. So I think these comments are very helpful that you made, and it brought to us some other perspective. Also really want to thank all the speakers that were available today, because all of you provided a different entry point for discussing this important topic of infodemic management and communication and health communication and fact checking. And I think as public health practitioners or researchers across Europe, we really also have more and more a role to play in this as well. So as Eleanor was saying, we also need to make sure that we are strong and that we are aware of this information that is coming across in different fields, that we make sure that we're at least not sharing this information that is not accurate. So we now know how to be aware of this and how to be careful in the way we spread messages and what we need to pay attention to. So take your time to go through the tool again and learn more about it. And then I would just really like to thank the whole unCoVer team for having organized this meeting, including David, Gloria, and Jose, and of course also all credit to Miriam from the FiRi side. So thank you so much, and maybe some last few words from Jose. Over to you, and thank you to all the speakers again.
Thanks, Petronille. I know, just underline your words. I think we've got very nice presentations and very nice information to work with. Remind you that the session has been recorded and that we will share it later on in our media channels. And just yeah, thank you all for your participation, especially the speakers. You were great. I hope to see you soon in the next webinar. Thank you.
Goodbye.
Thank you so much, everyone, and have a wonderful afternoon.